So today we are going to discuss the platelet transfusion. Now, who should be transfused? So let's see a patient who is bleeding. What are the recommendations that this patient should be transfused? Threshold for patients who are bleeding. If there is severe bleeding, which includes DIC as well, the patient may be transfused at count less than 50,000 per microliter. Similarly, patients whose bleeding is not life-threatening or not considered severe, they may be transfused at platelet count as low as 30,000 or less. And in the context of multiple trauma or intracranial bleeding, any patient who's got platelet count less than 100,000 should be transfused. You see, the transfusion should be tailored to the bleeding severity and the individual circumstances. Prophylactic transfusion thresholds. Who are the patients who should be given prophylactic platelet transfusions? Let's see in the clinical scenario what should be the threshold. For example, patients who got spontaneous bleeding prevention, if it is less than 10,000, they may be transfused. If it is more than 10,000, they generally don't require transfusion. Similarly, before neurosurgery or ocular surgery, the threshold is 100,000. So any patient who is less than 100,000, you're going for surgery, go for platelet transfusion. Before major surgery, if the patient has less than 50,000 count, go for transfusion. If the patient has DIC, again, the threshold is 50,000 per microliter. Before CVP placement, it is less than 20,000 per microliter. Before epidural anesthesia, it should be less than 80,000 per microliter where you transfuse. And then patients which are undergoing bronchoalveolar lavage, the threshold is less than 20,000 cells. And before endoscopic procedure, less than 50,000 if they're going for a therapeutic procedure like ERCP or where you are cutting inside, or in patients who got going for a diagnostic procedure which is low risk, the threshold is less than 20,000. If it is less than 20,000, transfuse, otherwise don't. During parturition, if the patient has vaginal delivery, the threshold is 30,000, and for cesarean section, just like surgery, it is 50,000. So anything which is less than 50,000, patient may require transfusion. And then before lumbar puncture, in patient who got hematological malignancies, the threshold is between 10 to 20,000, and if it's less than that, it should be transfused. And if the patient has no hematological malignancy, the threshold is 40 to 50,000 or less than that. So these patients may be transfused. So recommendations vary a little. For example, for spontaneous bleeding prevention, some of the authorities recommend a count less than 5,000, then you transfuse. Some recommend that it should be less than 10,000. Now, who should not be transfused platelets? That is important. Thrombotic thrombocytopenic purpura, because that adds, if you give platelets, there are chances of more thrombosis. So transfuse only if there is life-threatening hemorrhage. Similarly, in heparin-induced thrombocytopenia, transfuse only during or before the procedure, or patients who are having severe bleeding. Otherwise, the platelet should not be transfused. Similarly, in patients who got dengue, if they've got thrombocytopenia, they should not be given platelet transfusion. They should be given the whole blood instead of giving just platelets. Now, what are the complications? Febrile non-hemolytic transfusion reactions, allergic and anaphylactic reactions, transfusion-related graft versus host disease, transfusion-related acute lung injury or TRALI, post-transfusion purpura, transfusion-related immunomodulation, platelet refractoriness, circulatory overload, sepsis, bacterial infection and viral infection transmission, and hypotensive reaction. Let's see some of these complications in a little bit of detail. Febrile reactions. They occur within 4 hours of transfusion cessation. No other attributable cause can be found for febrile reactions. Fever greater than 38 degree oral or with the 1 degree centigrade change from the baseline, or if the patient has chills, consider this is possibly a febrile reaction. Stop transfusion, evaluate for other causes like hemolytic reaction or bacterial sepsis, and antipyretics may just be sufficient. Sometimes meperidine or pethidine may be needed to control the chills. And transfusion-associated graft versus host disease. This is rare but a fatal complication. This should be taken very seriously. Patient has fever with systemic manifestation in the skin, GI tract, liver, and bone marrow. Occurs usually within 1 to 6 weeks post-transfusion. Primarily affects the host which are immunocompromised. Congenital T-cell defects, low genetic diversity, or first-degree relatives with similar reactions. Diagnosis generally is of exclusion, but molecular testing can be used, and sometimes microscopy may be helpful. Prevention is achieved through irradiation of the platelet before transfusion. In suspected patients, in patients who are susceptible, irradiating the platelets may be helpful. Then allergic reactions urticaria, pruritus, localized angioedema. Sometimes you may have hypotension, wheezing, anaphylaxis. These are uncommon reactions. IgA deficient patient may be affected more than other patients. Treatment generally is antihistamine, bronchodilator, steroids, and epinephrine in patients who got severe cases. Transfusion should be stopped. Platelet refractoriness, that is, the platelet transfusions do not produce desired effects. There is development of antibody against human-specific platelet antigens or HLA, and then platelet cross-matching can reduce this complication, or otherwise we can choose HLA matched platelets or a matching human platelet antigen containing platelets that may be helpful. And then we may have trolley, ARDS within 6 hours without evidence of heart failure. The chest X-ray may show diffuse patchy infiltrates. The BNP is not high. Reducing amount of plasma by suspending the platelets and removing the plasma may be helpful for preventing this complication. Majority of the patient resolve with supportive care. Then patient may develop circulatory overload. Onset usually occurs within 12 hours. Results from repeated transfusions. Features of circulatory overload are present and patient may have high BNP. It responds to fluid restrictions and diuretics. And then infections may be transmitted, for example, hepatitis C, HIV, bacterial infections, sepsis. So all these may be possible with transfusion. The current practices of screening the blood are usually helpful in preventing these complications. And then post-transfusion purpura. 5 to 12 days post-transfusion is the presentation. Thrombocytopenia usually persists for days to weeks. Alloantibodies develop against human platelets or other platelet-specific antigen. IVIG 1 to 2 gram per kg per day for 2 to 5 days may be the treatment to control this post-transfusion purpura. And then patient may have hypotensive reaction. Hypotension during or within an hour of transfusion is completed. This may be a one presentation. This is generally seen in patients who are on ACE inhibitors. So screening for treatment before transfusion may be helpful in this condition. So these are the complications of platelet transfusion.